I'm really happy to be with you here today. Thank you, Olivier, for my introduction. It's very clear. And I tried to convince you that bicarbonate could be helpful in some situation. This is my conflict of interest, if I can. Okay. As you know, as probably presented by the previous speaker, severe acidosis in ICU is frequent between 20 to 40% in different ICU, and it's associated to worse outcome and a mortality up to 60%. And sodium bicarbonate infusion to treat severe metabolic is absolutely controversial. You have maybe some school, it looks like that's a good school, like or not, and the other who don't like. This is absolutely the real life. And then we performed 6 years ago a study which evaluated first the practice of the different ICU, who did not use it, and to evaluate the outcome of patients who presented metabolic acidosis. First results that we reported that a severe metabolic or mixed acidosis with a pH less than 7.2 is associated to a mortality between 50 to 60%. In our multicenter study, we reported 57%. This is the first result of this study, and we also reported in this study that there is different practices between the ICU and also in the same ICU, you have different practices between physicians. Some believe, some don't believe, and some are in the gray zone. And we also evaluated the evolution of the pH between the survivor and the patient who died. And as you see here, you have here the first day. At admission, you have all the patients have a pH less than 7.2, and at the first day and second day, you have an increase of pH only for survivor, not for non-survivor. This is absolutely descriptive, no interpretation. And also, when we evaluate the bicarbonate, we have the same results. That means between survivor and non-survivor, the survivor have a recovery of the physiological or normal value of bicarbonate. Again, it's absolutely only observation. Then the question remains always open at this period because we have no randomized control trial. We have only very little 2 or 3 physiological studies which have controversial results in terms of physiological variables such cardiac output or such different variable hemodynamic. Then the question, is it good, bad, or no significant if we use or not bicarbonate to treat severe acidosis? Then if we read also the different survivors sepsis campaign focusing on sepsis patients, the conclusion was the same for 2030 or to the last recent one, 2017, and no study have examined the effect of bicarbonate administration on outcome. That means have absolutely no data on this. That's why we performed this study called BICAR ICU, BICAR for BICAR, ICU for ICU.
Okay.
And everybody's happy. And this was the funding from the Ministry and from the French Anesthesiology and ICU Society. Then it was the aim of the study was to determine if sodium bicarbonate has an impact on the outcome of severely acidosis patient, and the hypothesis is bicarbonate will decrease D28 mortality or decrease a number of patients presenting at least one organ failure at D7 as defined by a SOFA score above 2. This was a composite score. We calculated this composite score because we don't have absolutely at this time money to have a big study. This is real life. And we evaluated the classical secondary endpoint. It was a large randomized control study, French center, 26 centers participated. It was stratified, I will show you stratification, with 2 arms unblinded. It was not possible to perform blinded because it's absolutely the real life, because if you use blinded, you will see the blood arterial gas and you have the value, in fact. And the analysis was performed in intention to treat, and we needed 400 patients, as I will show you. Then this is the inclusion criteria. The inclusion criteria should be within the 2 days after ICU admission, and the 4 following criteria must be present at the inclusion. That means pH less or equal to 7.2, PaCO2 less or equal to 45 millimeter of mercury, bicarbonatia less than 20, and a SOFA total score above or equal to 4, and or lactatemia above 2 millimole liter. This criteria we choose to use an absolutely pragmatic study for non-expert, for just guy like me, very clinician, very simple, and this is very important to have this type of study. We use the observational study to evaluate what the physician performed. The following are the non-inclusion criteria, as clearly presented by Olivier. Bicarbonate loss is, and I said again, is an indication of bicarbonate bicarbonate infusion, as always remembered by Carol, like all the digestive loss and tubular acidosis as previously presented by Olivier, chronic kidney failure, the acidoketosis. This is another discussion from some reviewers, and the classical exclusion. This is a design of the study, the experimental design. We have 2 groups of 200 patients, you can see. No bicarbonate in the control group, that means absolutely classical, and bicarbonate for this group, that means the interventional group, and we have stratification on center and stratification also on sepsis upon inclusion, yes or no, renal failure using the Akin score, Akin 0, 1 or versus 2, 3, and elderly or not elderly. This is the design clear of the study. You have the 4 criteria of inclusion, randomization, and here you have nothing to do, just the classical one without bicarbonate infusion, and you perform the classical practices using the blood arterial gases each 4-6 hours, and consider renal replacement therapy in the classical criteria. The interventional group is the following one. We performed a bicarbonate infusion of ISO 4.2% using a bolus infusion between 125 to 250 milliliter during 30 minutes, and you performed classically blood arterial gases 1 to 4 hours after. And the target is to try to have a pH above 7.3. If you cannot use 7.3, you perform again, up to 1 liter of bicarbonate. If you have this situation, probably you should consider, or previously, renal replacement therapy. This is the design. The results of the study is presented here. This is a flow chart. As you see, among the 400 underwent randomization, 194 were included at the follow-up here in the control group, and 195 in the interventional group. This is a kinetic of the arterial pH. As you see, all the patients have a pH less than 7.2 at inclusion, and it's easy to show who is the group who received or not the bicarbonate. This is clear, and the target of 7.3 was reached for the majority of the patient by bicarbonate and or using renal replacement therapy for the more severe according to the protocol. This is the arterial bicarbonate. Again, you have a significant difference between the two groups. And this is very important result as asked by some correspondents and some reviewer, the PCO2 value. This is a real life. You know that administration of bicarbonate increase PCO2 and the CO2 total. This is a real life, but probably, I don't know, but probably the physician change the setting of the ventilator and probably increase minute ventilation or tidal volume or respiratory rate in some situation to increase the ventilation and to maintain the PCO2 in the physiological range. This is the main result of the study. The primary outcome, which was a composite score of mortality and of organ failure, as you see, you have no significant difference for the composite outcome. Then, honestly, the study is a negative study according the primary outcome. However, the D28 mortality, you observed a difference between both groups. You have a decrease of minus 9% between the two groups from 54 to 45 with a p-value at 0.076 and no significant difference for the secondary at least one organ failure at D7 between the two groups. However, in the subgroup pre-strata, that a priori, with a patient with akin 2-3, that represent 182%, you have a significant decrease both for the composite score and for the mortality at day 28 and also for the one organ failure at D7. This is very important that when we have a selected population, we can probably have some positive results in this situation. This is a Kaplan-Meier from to the time to death in overall patient. As you can see, the Kaplan-Meier, the p-value is 0.89. The calculation for the number needed to have a significance was 50. That means for the future study that we plan, we have now planned a BICAR ICU 2 for the second one. That's thank you. And this is a Kaplan-Meier curve, not for overall population, but only for the pre-specified acute kidney injury. That's the subgroup. That is it's around half of the patients. And you see there is a significant difference between the control group, 63%, and decrease to 46% of mortality. This is the first time that we show a significant decrease in this population. This is the relative risk of mortality of the three strata, and you see the only net benefit was observed only for the acute kidney 2-3 population and tendency for the others. Note that there is no significant in sepsis patient in our study. This is a secondary outcome, and this is a Kaplan-Meier curve for overall population. For overall population, we have a significant decrease to renal replacement therapy required from 73% to 51%. And this is really a major result also for this study, which probably after listen Olivier, it's easy to speculate these results. And I will finish my presentation with this study. This study was just accepted in Intensive Care Medicine Journal, is in online since 1 week. It will be published on the November, and it's a nice study which evaluates on a large database the effect of bicarbonate in septic patient on mortality, overall patient with sepsis, and the others compared the patient who received bicarbonate versus those who did not receive. And they included 1,700 patients, 500 patients received bicarbonate, and the conclusion, I just summarize because it's absolutely nice study, no significant mortality effect in the overall population. in the study that some patients received bicarbonate without severe acidosis, but no significant difference. However, in sodium bicarbonate infusion was associated with improved outcome and decreased mortality in septic patients with more than 2 with kidney renal failure and pH less than 7. It's absolutely a confirmation of the BICAR ICU study regarding a large database. In conclusion, bicarbonate did not significantly decrease mortality or the presence of at least one organ failure at day 7 in the overall population with severe metabolic acidosis. However, bicarbonate infusion decreased the need for renal replacement therapy for overall population, and in the a priori stratum, because it's not a post-hoc analysis, it's a priori stratum evaluation of patients with acute kidney injury, bicarbonate results in a failure death by day 28 from 63 to 46 with a significant difference. Thank you very much for all the participants in this study. I want really to thank them because some of the participants are in the room, and thank you for your attention.
We're all excited on these results, and I'm sure that there are many questions. We have very little time, so I'll start off here, and if we have time, we'll have a second question in the back.
It's a great study. I spent my life convincing anaesthetists that intracellular acidosis doesn't exist and bicarbonate is good for you. So you've shown that. Do you think you can adopt this philosophy outside the intensive care unit using oral bicarbonate in the patients on the wards with acute kidney injury, which make up a huge group that we don't know what to do with?
It's absolutely a good question. First, I don't present to you the slide with the side effect. There was no side effect. There was no side effect with this protocol. That means using according to the protocol, the dose. This is clear. If you use more and more bicarbonate, probably we have side effect. If you use a lot of dose of aminoside, of vancomycin, if you use a high tidal volume, it's probably not good in ventilation. Then, according to the study, there's no side effect. There's no severe hypokalemia. There is no severe hypoglycemia. Then it's very strict protocol. I consider that the balance benefit-risk today, okay? We plan a very large study with bicarbonate ICU2 to try to better evaluate the impact on outcome on the selected population, including 1,000 patients.
But Louis is alluding to a bicarb hosp study, I guess. Yeah.
Yeah. Yeah.
We're already kind of urged out of the room. There's one question, I promise. So there's, sorry for this.
Thank you for a nice presentation. I would like to ask you, did you differentiate between hyperchloremic and lactic acidosis? Because the other study, there was still a positive relationship between mortality and lactic acidosis.
We did not perform exactly this, but some of our group asked this question. I don't have the data to answer you, but we will see. Honestly, no.
And because it's so sad, there was still one question. It was very short, so maybe the gentleman in the back.
There might be some patients actually who might have difficulties to get rid of their CO2. So did you excluded these COPD patients in your study, or did you just say, don't matter about it, just, push them all in?
Good question. We performed a pragmatic study. That means in our study, almost all patients have been intubated. That means all patients, except I think 3 or 4, received invasive mechanical ventilation under sedation. That means the physician set the ventilator. And for the majority, we have probably some COPD, but we try to do this to exclude the severe hypercapnia COPD. It's not the same thing. But we try to avoid to have a mixed ventilatory acidosis. Just try to focus only on metabolic and mixed acidosis. But it's a good question.
Okay, thank you very much.
Sorry for the...
Thank you very much for this
Thank you.
great study. And thank you very much to all the presenters and to the audience for being here in this late afternoon acid-base discussion.